The first question, perhaps Sarah, I'll direct it towards you, which is, so where is mental health care in the multidisciplinary team?
It's really important, and particularly with the recent judgments around deprivation of liberty, that actually we have enough qualified social workers making a real contribution to that multidisciplinary team. And we know that people will get better more quickly and remain in an independent situation at home more easily if their mental health needs are addressed. And particularly for the elderly, isolation and loneliness we know can lead to more enduring mental health issues. So picking them up early and making sure that we rehabilitate and re-able quickly is a crucial part of this.
It's interesting. Actually, at the break, a lady from Surrey Borders pointed out that her mental health team did get involved in multidisciplinary teams. Dante, what was your experience, is your experience within your health system with the role that they play?
Yeah, so I mean, I'd echo Sarah's point really that it is absolutely crucial that mental and physical health are co-delivered to older patients. And for a number of reasons, not least because I think there's a lot of unrecognised anxiety and depression in this group that's not well managed, and that complicates delivery of physical health care, both in interpreting what's wrong and delivering a solution through the pure medical lens, if you like. But also, cognitive frailty is not often recognised either, and we often unmask it on our unit. And then we kind of feel that we are kind of struggling to kind of catch up and work out how do we tailor a package of care that is right for the patient, the care of their family, balances risk and autonomy. And I think mental health expertise is absolutely crucial in delivery of that. Now, the community trust that hosts this unit, it was in fact a mental health trust originally, okay. and there's both, so that there's expertise embedded in the institution. And the acute hospital, Oxford University Hospitals, they've strategically have employed their own psychiatry service, the liaison psychiatry, sort of a psychological medicine service, recognising the core or the crucial element that mental and physical health care play together in patients who we think it's just a simple physical illness. It's not actually. There's always a psychological component, and so this is two trusts coming together who both absolutely understand that you can't talk about mental physical health care in isolation. You must understand them together, deliver them together, and assess them together. Delivering that on the ground in real time is more of a challenge because services are still quite set up to be separate, if you like, even notwithstanding what I've just said. So on our EMU, I think we still have some way to go from my perspective, where I feel we've got real-time co-delivery, joint assessment from both mental and physical perspectives of a crisis situation. But that has to be the goal, and that we have to deliver that rapidly, I think, to kind of release more of the true innovative power of a sort of platform such as that unit. Okay,
lovely. Now, this next question is directly for you, because it says here for Dan Lasserson, and this is about kind of your health system and the kind of future hospital and the model that you were describing. So what savings have been delivered across the system to make this sustainable? Has funding actually shifted between
This is interesting. And I think I'd place the answer to this question in the context of the inexorable dramatic rise in demand for acute hospital-based healthcare. So medical admissions in our area have risen over the last 4 to 5 years by up to 30% in some locations. Oxford City increased 30% for the over 65 patients. So and elsewhere across the country, people report year-on-year rises in the number of patients who need an acute hospital admission in general medicine. So when we talk about what do these units do, do they allow you to kind of move money around? You're looking at, actually, this isn't a static need. Need is increasing all the time. And I think what units such as this do, so for example, I've looked at the data in our area, and say for the first 4 years of operation, we managed to limit the rise in acute medical admissions from the area where we were seeing patients. So you don't see a dip in admissions, but you mitigate something of the background rise. At which point these units don't empty hospitals, but they might stop us having to keep building new ones every so often. And I think it's understanding that an out-of-hospital care process or platform, if you like, is not going to allow you to just suddenly remove whole chunks of hospitals. And part of it is also about the lumpy nature of costs in hospital. So there'll be like, wards or number of bays. And if you've got, if you have a continuous reduction, or the hospital won't be able to release any of that until they've got enough to take out a whole block of something.
It's relatively fixed.
Exactly. They have lumpy costs, whereas we can do the things.
Do you think we will get to a kind of sort of pound per unit of health outcome or healthcare outcome? Because that's the comparison, is it?
I guess you could say we have that already. We can see what we do and what are we spending. And then the question is, I think, what are the delivery mechanisms to achieve that outcome, and have what contributes to that outcome? Is it a simple clinical measure? I'd argue it shouldn't be that. And what what value are we placing on patient and care experience as well?
Okay, well, it's probably one for and I had my own question there. So thank you very much, Dan. Lovely. Okay, the last question, and I think, Sarah, perhaps it's kind of one for you to start with, which is about utilising voluntary care. So how can acute care utilise voluntary care, e.g. the family, for re-enablement of frail people before and after discharge for better outcomes and reduced bed blocking?
I think the key to this is people knowing that a discharge doesn't mean a complete change of the care plan or the support that was going on. So really early conversations, hopefully around the GP's role and the primary care team and the multidisciplinary team there, that actually if you go into hospital, it's to be treated for the condition, and then you'll come out and things will resume. And I think what we've still got too much of is a sense of huge relief, particularly for family and informal carers, that someone's gone into hospital and everybody else is then going to sort it. And that's for very good reasons, with some of the very high dependency levels that family are caring for. But it's about the minute people go in talking about discharge, talking about what the options are, talking about getting mum, dad back on their feet again, getting them back home with possibly increased support but not a completely changed home environment. And also getting people to support people in a way that actually means that, particularly where you've got dementia-friendly communities, people are dealing with really quite extreme behaviour sometimes and physical conditions. And that is all achievable if you've got that attitude and that environment there. So I think it's that very early discussion with people when someone's admitted to hospital with informal carers, that this doesn't mean necessarily that mum or dad is going to go into a home, or that things are going to change dramatically. I do think that actually we could be doing much more to train formal carers and informal carers to do some of those things at home that we would previously have expected others to do, and to do many more treatments at home. We all know about the IV at home for dehydration and other things, but there are ways of managing incontinence and ways of managing people at home that could be a real protector for the need for an admission, really, and actually engaging informal carers in skilling them up and training them to be able to do that. It's what they want, because they don't want to feel hopeless, but we don't do it very often.
Okay, thank you. Dan, just briefly, have you had any of that experience with your programme in Oxford?
Yeah, and I think informal and voluntary components of acute care for us are absolutely key, absolutely crucial. And for certain patients with certain presentations, they're really important. So patients with confusion, for example, if we think we found a medical cause that has an out-of-hospital treatment, finding the right balance of risk in the home environment is absolutely important, because a confused patient in hospital will get more confused. And so we have to think about what's right for this patient, but also how do we mitigate risk about being in the home environment. And we find that family and informal care is an incredibly important component for that, and I think allows us to have a much better outcome for the patient than if we'd admitted them. Okay. But for me, I see it as a two-way street. That's quite an ask of families. People have jobs. This is a complex environment to work in, generally, and people are we sense the stress of modern working life, and people can't just down tools as much as they may want to. So then I think the ask of us then is, as well as supporting the patient and the assessment of them from clinical and therapy perspectives, what can we do to support families and carers to help deliver that, and understanding the stress that we may place on the caring arms, if you like, around that patient. And I don't think we do that as well as we can. We just need to find out more to do it. But I see it as a two-way street. This is an ask, it's a new ask of patients, but of families. They're willing. They want to be involved in care. They want to be involved in it. They see it very much as they see the home environment as the right place very often, provided we've demonstrated that actually we are clinically addressing the underlying medicine, and they do want to help create that better experience for recovery. But I don't think we yet know how best we can support them to do that.
Lovely. Thank you both very much. Thank you for coming along this morning in your presentations, and thank you for taking the time to answer those questions.
It's a great pleasure. Thanks for inviting me.
Thank you.